liver function. Some of these things, people that have, okay, what will I recommend for you? I'll still get there. Yes, as a gynecologist, I will now talk about this one, at least one that concerns me most. Okay, what I've done now is to talk for generally, which I know will help everybody. So now, as a gynecologist, I will talk about uterine fibroid. This will benefit the women on the platform. Uterine fibroid is not a cancer. It's a tumor, okay, but we call it benign tumor. It's just an outgrowth of some tissues in the uterus or around the uterus. However, it is not a cancer. Now, if somebody is so careless about it, he has had it for years, he's not doing anything about it, and the thing keep growing and keep spending years, there is something we call malignant transformation of uterine fibroid, meaning that the fibroid can become cancer. Yes. So, but that's very rare. It's very, very rare. So I said that to let you know that whatever thing you are dealing with, don't be careless about it. Don't say, Shebi, they said it's not cancer and things like that. No. Take good care of yourself. Whatever it is that you are seeing that is not normal, go and meet a doctor and check it out. Know what exactly it is so that you have appropriate treatment. I'll still talk about some things about belief and, faith and medicine. How some people think that if I have faith, I cannot see doctor, I cannot, and things like that. I will tell you how it has injured and killed many people and sent some people to early grave. You understand? There is a balance between the two. I'll get into that also. So type of fibroid, basically we have what we call intramural fibroid, meaning that I'm sure you can see this picture. Okay, this picture is showing us uterus. Okay, this thing you are seeing here is tube. Okay, we call it fallopian tube. Okay, this is fallopian tube. It's also at this other side, fallopian tube. Now, permit me to say some things. The male people among us, don't mind. This is a gynecologist. These are things I work with. So please just don't mind my word now. This thing you are seeing here is vagina. Okay. So this area is cervix. Okay. So now inside, sorry about that. So now I'm trying to show something. Okay. So this place is what we call cervix. Okay. So if you trace it up, this whole place is called uterine cavity. Uterine, this is where baby grow. Okay. Inside this thing, it will be blowing like balloon as baby is growing. Okay, up to 9 months. Now, this thing you are seeing here is a disease womb. This picture I'm showing you is a disease womb. Okay, there is something we call endometriosis. You see all these black something is what we call endometriosis. Okay, the one inside the uterine tissue. Okay, we call it adenomyosis. Don't worry, I'm not trying to make a gynecologist, but I'm just trying to show you as much as I can. As much as we can take. Let me put it that way. So now, fibroid is what we are talking about. This is a fibroid. This whitish thing is a fibroid. Okay. This other one you are seeing here too is a fibroid. Now, this one is not so big as it were. You will see some fibroid so big. In fact, there was one we did this week. It was so big, in fact, multiple. You can see this whole place full of fibroid, and the woman is carrying like 9 months pregnancy, and you're wondering, is this woman going to deliver tomorrow or something? And you notice that for years, the thing keep being like that. That is fibroid. Now, I was talking about the types. We have what we call intramural fibroid. Okay, this one grew within the muscular wall of the uterus, like this one. Okay, submucosal fibroid. grow just beneath the uterine lining. Now, this thing that is pink like this, is what we call endometrium. Is the internal lining of the inner lining or inner layer of the uterus. We call it endometrium. When a woman, okay, what happened is this: every month, this internal lining is preparing to receive a fertilized egg, like is expecting a baby every month. Okay, it's my cursor. Okay, inside this place, this pink part, not all these uh, particles. Though. Inside, just imagine that all those particles are not there. So inside that place is uh, is always preparing like a bed to receive a fertilized egg so that it can make it to grow to a baby. However, if there is no fertilized egg that will come there, that place will slough off. Okay, all the thing that has prepared like bed, they will wash off, and we call it a weeping womb. Every month, when there is no fertilization, when there is no implantation of a fertilized egg, we call it a weeping. If the thing just cried, oh, I didn't receive. Okay, let me prepare for another month. So another month, the day it starts, the menses start. That's the beginning of another month. So then they prepare again to want to receive. Then when nothing happened, the things slough off again or wash out again. Then the woman sees blood. So that's that. So then this is what we call pedunculated fibroid. Okay. Now this subserosal fibroid, this is the fibroid that grows towards the outer part of the womb. It can grow towards this outer layer. Okay. So then we talked about pedunculated fibroid grow on stalk-like structure attached to the uterus. If you take a look at this one, this is a very perfect example of what we call pedunculated fibroid. Okay. So that's I really hope I didn't bore you with too much of details in that area. This is another picture of fibroid. This is another picture of fibroid here. This another one, this another one, this another one. Okay. This one is the one within the muscle. This one is the one close to the internal lining. In fact, these are the ones that make women to bleed more because they are close to the place of bleeding. So that's the one that some women may not have big womb like that, but they have plenty of that thing around this place. Plenty of them around this place. They may bleed the more. You may see somebody that has like 9 months pregnancy womb, and yet is not around this place. She may not be having heavy menstrual bleeding. She may not be having that heavy bleeding and all that. And yes, the womb is like 9 months pregnancy. So then uh, hormone factors, yes, the possible causes and risk factors for uterine fibroid. Hormone factor, okay, estrogen and progesterone stimulate fibroid growth. Genetic factors, that's another important thing. Some people, it runs in their family. Somebody will say, my sister has fibroid, and by the time she's also noticed she's having heavy menstrual bleeding, we notice, okay, from the investigation, from everything, she also has fibroid. So it can run in the family. That's what that means. Then age, between the ages of commoner within between the ages of 30 to 50, commoner. But yet you can see somebody age of 25 and has fibroid. So it can be at any age as long as you are in reproductive age group. So then ethnicity is commoner in African American people, uh, unlike the Caucasian. It's not as common in white people, Caucasian. Somebody just noticed, my menses, I used to menstruate for 3 days. All of a sudden, 4 days, it has not stopped. 5 days, it has not stopped. And it's not looking like it's on to stop. 6 days, then she'll come to the hospital. Doctor, I don't know. I noticed that I've been using 2 pads per day, but now I'm using 5. In fact, in the last 2 days, I've used 6 and 7 and things like that. So that's the usual way they come with their complaint. Then we now ask them other questions and also examine and investigate to make the assessment of uterine fibroid. So then pelvic pressure pain, yes, this is another problem they can have. Like I said, for every woman that has carried pregnancy, that pregnancy as is growing, bigger and bigger. By the time you are getting to 20 weeks, 25 weeks, 30 weeks, 35, 36 weeks, you notice that that thing, the way you are walking is not like the way you were walking when it was 18 weeks or 10 weeks. You notice that there is a protrusion, in your abdomen, and you have to walk more gently. There is a pressure, that there is a pressure that is going towards, your pelvis. So it causes that discomfort. So for those that have huge fibroid, it gives them a lot of discomfort. And then abdominal swelling, bloating abdominal swelling is another thing. Another thing is because of the size of the fibroid, it can compress the pipe that is conducting urine from the kidneys. We call them ureter. See, from the kidney I showed you earlier, the kidney will filter urine, okay, will filter blood and produce urine. And when the urine is coming through the pipe, it's going to bladder. That bladder, when it is full, you feel like you want to go and wee wee. Now, hello, can we still hear me?
Yeah, we can hear you now.
Okay, thank you, sir.
You-
Okay, there was a network that disrupted my network, so I had to quickly take it off. So, okay, so I was on uterine fibroid. So, heavy menstrual bleeding, pelvic pressure or pain, bloating and
have to
swelling,
reshare
urinary.
your screen, sir, please.
Okay, sir. Okay, sir. Okay, sir. Is it back, sir?
Yeah, it
Is it
is
back, sir?
back. Thank you.
Okay, thank you, sir. Okay. I was talking about urinary frequency. Now, if the thing compressed on that pipe of that is taking urine from the kidney to the bladder, it can cause a backflow of urine. Like as a result, the urine will be going back to the kidney. We call that hydronephrosis, and that time it can affect the kidney. It's not affecting that pipe. Say the urine is getting to the bladder, but it's now compressing the bladder. It makes you to feel like your bladder is full when your bladder is not full yet because it's pressing or it's reducing the space of that bladder. So one of the things that they come with is they urinate frequently. That may be another problem with that condition. Yes, infertility. Does fibroid cause infertility? Not exactly. Fibroid does not, but it can interfere with fertility. For example, depending on the location of that fibroid, if it's somewhere around the tube and is blocking the tube, say the thing is compressing the tube somewhere, it can prevent the flow of sperm to where the egg is and can as such affect it. But we don't often say that fibroid is a cause of infertility because many people can have fibroid that is big and yet they get pregnant. It will now become a war between the pregnancy and that big fibroid. But oftentimes, some of them win with the fibroids as big as something. Some of them may still, carry the pregnancy to some 34 weeks, 36 weeks, and still deliver. But it's not a good experience because the disturbance, the challenges of pregnancy is there. Then, in addition to now the pain of fibroid in pregnancy, all the other challenges, then it can also cause miscarriage. Fibroid in pregnancy or fibroids with pregnancy can lead to miscarriage of that pregnancy. For example, if you notice, there are some I showed earlier that they are on the endometrium, around the endometrium. So if the pregnancy or if the fertilized egg is implanting in that area where fibroid is as if you are sowing a seed on a stony ground and you know that that thing will not grow. So that's the way it is. If it's going to implant around that place where fibroid has taken up, it will, just like I said, sowing a seed on a stony ground, it can make the pregnancy to come down. So those are the problems that can come with that. Then the investigation we do, usually we examine the patients. We also request for investigation like ultrasound scan. Basically, ultrasound scan may be fine. Most of the time, we don't do more than that to investigate fibroid. But if you are not clear with what you are seeing with ultrasound scan, you may need to go ahead and do MRI or CT scan just to be able to see clearly what's going on there. Sometimes somebody may have more than fibroid, may also have some ovarian cyst, ovarian tumor, and things like that. So if it's not clear, we escalate to higher investigation. Yes, hysteroscopy. It's an investigation that we use to see the inside of the womb. We pass the instrument. The instrument has camera on its head, so it's in theater we do this and pass through the cervix to see the internal part of the womb. What are the things causing this problem that this woman has? She's having heavy menstrual bleeding. She's having this, she's having that. So we use that to check what's going on there. Then also we talk about what we call, the treatment option for uterine fibroid. Sometimes if it's not disturbing the woman, say she just did a scan that shows she has fibroid and the fibroid is not big enough to disturb her, we oftentimes don't worry anybody on that. But when the fibroid is disturbing, then we may need to intervene and do something about it. But usually we do what we call watchful waiting. Then for women that are close to menopause and fibroid, we may not bother them because we know that what is feeding the fibroid is about going, which is the estrogen and the progesterone. So when women enter menopause, the estrogen level goes down, progesterone level goes down. So what is feeding fibroid is also not there again. So fibroid effect. So that's what we do in those cases. Then medication, there are drugs we give to reduce the effect of fibroid. Oftentimes, drugs don't treat fibroid though. It's not like there's a drug that will remove the fibroid. Yes, there are some drugs that reduce the size of the fibroid. But how effective is that? From what we have seen and study has shown, it's just when you are planning a patient for surgery and you think that thing, you want to reduce the size a little bit. Yeah, you may give that drug to reduce the size a little bit. But then when you now get to surgery, you may discover that the ease of removing the fibroid may not be there because the cleavage, the way to separate those things and remove the fibroid is not as easy as it would be if probably you didn't give that drug. So you can see the drawback of giving, a certain drug to help to shrink. So then people stay outside. The traditional people that they give this one is to cure fibroid. Many of them are saying what is not true. So it's important for me to stress that many of them are saying what is not true so that nobody fall into the net of such people. Some of them even use some of these our drugs and put many things together and make concussion and say, if you take this one, it's side effect of those drugs. They don't know the dosage. They don't know. They just put things together because they are just quick to make money. So people should be careful with such thing, with those kind of people. Then surgery, yes. What is the definitive management of uterine fibroids? Fibroid. The the definitive management is removal of the womb. So the best way to manage fibroid is to remove womb. But that it can only be done for a woman who has completed her family size. She has born all the children she wants to born, and she thinks that why am I still keeping this womb? We can remove it. Why is it good to remove the womb? If the woman is certain that she is done with her family size, because the fibroid can grow again. That's the reason why that removing the womb may be a best option. If fibroid grow again and is disturbing her, she will need to come for another surgery. So if she's not using the womb again, the womb is not adding any benefit to her in any way if she has finished her family size. Yes, some people talk about, okay, if I come to another life, will I reincarnation, we call it. There is nothing like that. I'm sure as Christians we know that. So then myomectomy is the removal of fibroid for people who are still uh, interested in the future fertility, like they still want to have their children, more children, or they have not even had any. Yes, the best option for them is to remove the fibroid and keep the womb. So then there are other things we also do to manage fibroid. One of them is minimal invasive procedure, what we call uterine artery embolization. And there is something we call IFO. Yes, I have a patient. The patient we even operated this week has done IFO before. So the IFO is a it's an attempt to lyse the fibroid. It's just like you are putting an instrument, okay? You are putting an instrument on the womb of the woman to help to lyse, like to break down, as it were, the fibroid tissue and all that. But the that patient, I mean, a particular one we operated this week was even someone that had that procedure done some times ago, and it didn't work for her because it was already big. So if it's a small fibroid, yes, IFO and some of these things may help significantly. But if it's so big, I think that, I mean, from knowledge and from all the things I've handled, it's always best to remove the fibroid through surgery or to remove the womb. Then what are the other complications? It can cause anemia, shortage of blood, because somebody is having heavy menstrual bleeding. Some of them may come with PCV that is so low. Some people may come with 12% of PCV. You have to quickly admit them because at that point, the heart can give up. The heart is pumping low, far, far low than what it's supposed to have to pump. So it's overworking itself to maintain balance with that shortage of blood. So some of them can have heart problem. So on account of that, we have to quickly give them blood when they come. Then I've talked about infertility the other time. Also pregnancy complication. Yeah, I've talked about some of these things. They can increase the risk of miscarriage. It can cause preterm labor.